just start off by finding out where you went to medical school?
I went to Wayne State Medical School.
When did you graduate?
1954.
What made you want to go to medical school?
Oh, I don't know. My mother went to medical school, but only went through 1 year because of financial things. And she went to the University of Michigan, and she quit, and then she became a nurse. So maybe from childhood she sort of got me interested.
Okay.
There are many things that go into that, but you know, that's one of the basic things.
After medical school, where did you do your residency?
I did the residency in Worcester Memorial Hospital.
And when was that?
In 1955. I interned in those days, most people took a rotating internship. There were some straights, but straight internship, as we do now, most of us straight internship. But in those days, a lot of us took rotating. And then for various reasons, I came here from New Jersey. From New Jersey, came here.
What were some of the, if you don't mind talking about, what were some of the reasons that brought you to Worcester? Or why did you stay in Worcester after you were finished here?
Well, I didn't stay in Worcester. One of the things was that I wanted to do overseas work. And when I applied to Christian boards of boards who are sponsoring boards, they said, well, you need some surgical skills. So I said, okay, and I applied for various places, and Memorial Hospital seemed interesting, and that they had an interesting program, so I applied here, and I was accepted here.
What was your residency like?
Residency like? Well, it was a straight general surgical residency. I probably not much different than now. You worked hard and you got up early and stayed late, and it ended up as being chief general surgical resident, in which you were responsible for conferences. You were responsible, and you did all the operating. In those days, well, before Medicare and things, there was a lot of indigent patients, and the surgical residency tended to take care of those patients. There were 3 surgical residencies, I think, in town. One was at St. Vincent's and one at City Hospital in those days, and Memorial. And they had a very good, well-trained surgeons here who taught us, and we rotated through the various subspecialties. We also had 6 months in pathology, and we were trained in pathology. We didn't leave the campus. So it was confined to the campus. You didn't go to a lot of residencies now. You go from hospital to hospital. They have combined residencies. We didn't do that. We stayed at one place, and you worked yourself up from junior resident to chief. It was a pyramid system in those days. You don't have many pyramids now, but you were selected each year either by your self-selection or and possibly by whether the attendings felt you were competent to stay in and become chief. So if you didn't become chief, then you had to leave. It's based on the Boston systems.
What happened to those people?
Well, they would either go into another residency, another subspecialty, or they would just maybe go and practice sometimes. It was different kinds of, in surgery in those days was sort of different in a sense. Memorial was a very well-trained group of attendings who had been through the Boston systems generally. So they were very well trained there, and then they went to the SIS, and so they had a lot of experience. But some of the way surgery was practiced was that you were at a hospital, and surgeons came from Boston and operated, and then the people in the hospital took care of the patients post-op. It was sort of a I don't know what. Sort of itinerant surgeons. I mean, you just gotta make a circuit. Guys that come from the Brigham or someplace and Mass General, and then they'd operate and go back and come back the next week. So.
How long did that last?
I guess it lasted into about into the 60s, maybe so, the 70s, until the hospitals themselves developed. I mean, I remember Fitchburg was one of those hospitals, developed their own surgical people. Remember, residencies became very popular after World War II. Up to World War II, people didn't go into the specialties as much. They were general practitioners, and they practiced, and the subspecialties were, and the larger specialties, OBGYN, and were people who wanted to do those fields and didn't or practiced anyway. I mean, there were a lot of general practitioners did surgery, did obstetrics, and did anesthesia in a lot of local hospitals, even to the 70s and 80s. So there was a different kind of medicine there. Because it seems archaic to any student like you people nowadays, archaic the way we practice things, but.
That's interesting to hear about the way things changed.
Yeah.
So you said you did some more work after you left.
Yeah, I really was into family medicine. I mean, I was a general practitioner but I was asked to do this, become technically skilled in surgery, because I was going overseas. And actually, it didn't matter that much once you're overseas, because most of my bulk of my skills were in general medicine, pediatrics, obstetrics. And surgery, I would do it like 1 or 2 days a week, and depending on where I was, I did different kinds of surgery. Major surgery some places, and I did reconstructive surgery, and the skills were beneficial, but I could have just probably gone over as a general practitioner. But the training was good, so I felt I was competent.
How long did you spend overseas?
About 13 years,
Really?
Yeah, in India, yeah.
All in India?
All in India, all in South India, yeah.
How was it like practicing medicine there?
Well, get a lot of volume. Those days, I used to see patients 6 days a week. I mean, 6 patients, outpatients, seeing, and we'd see 100, 120, 20 patients a day. And we work from 8 till 8, 12 hours. A little break for lunch, but not much of a break. I mean, it was just too many. And you didn't know how you could manage, but you did. And then you had to make rounds at 7 o'clock or 6 o'clock in the morning, and then you'd go see all these patients, and then you have to take care of emergencies, deliveries. The hospital had a good midwifery service, but we as physicians took care of the complicated things like forceps and cesarean sections and all that stuff.
What was a typical day like when you were practicing in India?
Well, you get up about 5:30, and then you have breakfast, and you go to the hospital, and you just start working all day. You just see patients till there was no patient left.
What did you see over there?
Yeah, there were less of the chronic disease states. Maybe arthritis or osteoarthritis people had because of the hard work. But you'd get a lot of parasitic diseases, venereal diseases, malnutrition, infectious diseases mostly. Things you don't see, diphtheria, tetanus, people getting those things, and rabies, and not just prevention, but you'd have to do that. And then we did a lot of preventive work, because as they say, the bigger bang for the buck, the more you can prevent, the better off. The better off you can. So we went out to the villages. We used to go out there once a week and see people out there and try to get them. Eventually, when we trained people who were high school graduates, to work in the villages and take care of minor stuff, you know, rehydrate kids and tell people not to do certain things and take care of themselves, take care of how they got rid of waste and all that stuff. So that was very effective, we thought. And that was what's the trend is that overseas stuff is to missions or large populations like that. You try to deal with prevention. You know, you prevent AIDS. Someone getting AIDS is better than spending all that money for treating people with AIDS.
How do you think that aspect of preventive medicine overseas has come along compared to the United States, or just in terms of helping the overall health?
Well, I think we're up to maybe until the 80s. I don't think we were interested in preventive. Doctors not trained. I don't know if you guys are, but we're not trained to be preventive people. We have courses, and I had courses at medical school about public health. It was very boring. Most people didn't care much about it. They took it because they had to pass their boards and stuff. But preventive medicine is not very exciting, you know, like surgery. Saving someone at 3 o'clock in the morning is more exciting. But so over there, I think we still have a long way to go. We're doing it more now. We're preventing, you know, people eating the right things, exercise, and trying to get our health, maintain our health, rather than treat diseases as they come up, which is a lot of doctors, you know, a lot of doctors in office practice where I practice, same way. We didn't. It just seems harder to do, and it's not reimbursable. I mean, there's a lot of factors. Money costs. But when you have a little bit of money, like overseas, you need to have a chance to do more things with a little bit you have. I mean, digging latrines are much better than treating hookworm. Or wells, you know, preventing people from getting parasites from waters that they walk in, you know, groundwater. Then you put wells in, and they can't do that, so that disease is prevented. Cholera, typhoid.
What prompted your return to the States?
Well, we thought we would stay over there for a very long time. We had our children there. We had 2 children here and 2 children over there. My wife she taught nurses. But we sort of worked ourselves out of a job, meaning that was one of the purposes. We trained people, or they got people to replace what we could do. Especially when we did reconstructive surgery for patients with leprosy and stuff. And they have people who we trained, or they learned how those skills. There was no need for us to be there anymore. I mean, we could have stayed, but then you're sort of redundant in a sense. Where people there, plenty of Indian doctors were there to do the work we did, so we returned.
Was it difficult for your family to be over there with you at that time?
Not particularly, no. The only thing is that you have to send kids away to school. You could have them stay. You could teach. My wife did home teaching, which is okay. I mean, it's just a little tough. But anyway, with discipline problems. And but so you send the kids away from school, and my first son went away to school at 7. That's hard.
Wait,
Those,
away from home, right?
yeah, going up to an English-speaking school. International school, because they have to, you have to come back to this country, and you have to come back to a different curriculum. So the curriculum there is what is taught in this country, so that they can get the transition okay. So that was a hard thing, having the kids go away, because we didn't see them for months, and then, but it wasn't so hard on them. They seemed to enjoy it very much.
Clearly it had been on your mind that you were going overseas. What prompted you to go, and why did you go to India?
Well, it just, I felt I could do some other type of work over there. Then, I mean, just in those days there was a lot of feeling that Americans could save the world, I guess. Well, I don't we didn't do a good job, but still. But you know, it was some of that feeling throughout. Everyone came back after World War II and felt they could make a difference. So, and that is there. I don't know if that was part of it, and the excitement and going over the ocean and all that stuff, new countries and seeing new people, all that. There's a lot of factors in there. What was that part of the question? I didn't get that.
Why did you go to India?
Oh, well, it was, when you go over, they give you a list of places to go. And they tell you what kind of place it is and whether you want to go there. And I was given 3 or 4 places in South Africa, and one in Borneo and one in India. And I didn't want to go to South Africa because in those days the government was controlling, even in Christian hospitals, they had control over who could be seen and all that stuff. So I said, okay, I'll go to India or Borneo. So we went to India. I mean, they selected me out. They said, yeah, we need you in India. So we went there. We're going to Borneo.
When you returned to the United States, how did your experiences in India affect the kind of practice that it here?
Well, I probably had to toe myself down. Why? Because I came here you could ask me why I came, or ask why I came here. Well, I was trained here. I met my wife here. She was born in Worcester, lived in Shrewsbury, and she was a nurse. And I met her at Memorial, and we got married, and her roots were here. My parents had, meanwhile, moved to over there in Eastern Mass. My sisters were here. So I said, okay, we'll go to Massachusetts. Go to other places, but when he came back, I wanted to do general practice. I didn't have any really idea of being surgeon. Surgery was fine. I liked to do it. But I couldn't do reconstructive surgery without going through another whole training period, you know, and it was different. So I felt that I had to not do some of the things I could do out there in India. You get sort of wild. I mean, you know, I can do that. I can rotate skin flaps, and I can do all kinds of things, and I can, but I can't. In the context here, I just decided to back off. And I mean, some things of orthopedics, and which I had done some more training down in Boston and stuff. It was useful being a family physician, because family physicians do lots of things. The only thing about family physicians are you have to limit to what you can do skillfully, right? You can't counsel people very well. Don't counsel anybody. Refer, right? But we shouldn't get to the point where we're saying we do anything perfectly. We can't. So that's why that in a sense changed the way I practice. So I had to start being a regular family doctor, which I had been, but I mean in a different context.
Did you go into private practice when you came back?
Well, in a sense, no. I became an employee of Holden Hospital. Just a little brief about that, because in those days, family practice was starting to be a specialty from general practice. General practice was there up into the 60s, and then they constructed a board of family practice, American Board of Family Practice, in the late 60s. And they were looking to train residents in family practice. And so Holden had set up a health center in Barrie. You know what Barrie is? Yeah, okay. Some people don't know what Barrie is. and they set up this health center, and Dick Walton, who was part of Holden Hospital, also wanted to start residency. So I came here, and they heard about this through another doctor, and I applied here, and they went through. And at one time, I thought I wasn't living here at the moment. I was in Connecticut, but I thought I might go to Michigan. So I'd been trained, and I was offered a position there. But then Dick called and said, "Came here," and I'm glad we did that, because Gene Roy, who had practiced in West Brookfield, he had got this practice going in Barrie, and I came next, and that rest is, we just went on from there. His rest is history, because that was a 73, and in 74 we started the residency. So we had a short time to prepare and get going. And there was a touch and go thing because if you ever start a practice anywhere, you don't sort of start a practice and people are waiting in the waiting room just pouring in and seeing you, because most patients have their own connections with family, with any doctor, you know. And they don't want to, even if they has to go 25 miles or 30 miles to see a doctor, they don't know what kind of doctor you are. They don't want to change immediately. So it took about a year. And I don't know if you know a man named Dean Suter. He's got his plaque up here, right? He was dean here then, and he would come by when he went over to UMass and come by and said, "How are you guys doing?" And we'd say be one patient there. He'd say, he was worried about us. But then by the time the residency came into being, and we started with 4 residents, we had enough volume of patients.
Who were your patients out in Barrie at first?
There were people from around the town there. There'd been some agitation for some time to have more medical care. There was only one doctor who was practicing, one, maybe 2, but one was sort of almost retired, and there was another doctor there. And there was a lot of agitation for people in town to get some, because they had to go all the way to Holden or Worcester or Brookfields to find physicians. So, and Holden at one time started to have a 1 day a week they would come there, and that didn't work out because patients don't get sick once a week. So eventually they applied for a grant, and they got this grant, and they got this carriage in place, and they set it up, and it was there. And people came. We said we would take care of people from 9 towns around there, and we still limit our coverage because though we have patients from Worcester and Gardner and Fitchburg and stuff, but it's just too hard to come over in the winter. Demographics tell you where things are. If you live on a hill, you go downhill to get anything, to go to the 7-Eleven or whatever. You don't go uphill, or you don't go back. So that was the thing. So we limited by geography. If you know Central Mass and the Highlands up there, Wachusett Highlands, it's in the winter determines what your population is.
Not from Pittsburgh, so.
Yeah, well, that's right.
Okay. When you were a resident in Worcester, and then later when you came back, do you think all patients who needed care got care?
In those days? Well, I can't really say. I would think most doctors, if you came, we didn't have Medicare. There was no Mass Health, all those things. But a lot of doctors gave a lot of free care. That's my impression, you know, and I probably was true. I think if you were a minority group, you might not. For prejudice, for racial prejudice or something, you wouldn't get care. But I think the majority of people could get some kind of care. Remember, City Hospital, you could get free care there, and anyone could just walk in and didn't have to have any insurance or anything. Remember, insurance plans didn't really come in until sometimes in the 50s they'd have it. They'd have insurance, but costs weren't that high compared to what you earned. Still, it was still expensive. It was still expensive to get medical care. And hospitals, I remember hospitals gave free care. They were always after the residents to try to cut down the costs, try to get people out who were free care. But I would think maybe so, but I'm not absolutely sure. People in those days might have had the impression that they didn't get as much free care. But you know, you didn't, you relied on grandma's medicine. You didn't always go to see the doctor. You went to see the doctor when you were in bad shape. You went to the hospital to die. People they didn't have to go to the hospital otherwise.
How have you felt access to care has changed with the advent of the HMOs and the managed care?
Well, I think there's much more control of the managed care system on who is seen and how much you got. But you know, you gotta look at it in context. If you went back in time to the 50s when I started to practice, I mean when I was a resident and getting out, training, what you could do to patients was minimal. I mean, medication was minimal. You had a lot of medications, but there were no proven use of whether they would work. Hydrochlorothiazide, which was one of the first diuretics. There were other injectable diuretics, but the first by pill form, it came out in the 50s, early 50s. And the drugs like tetracycline, those came out in the 50s. Well, just before that, penicillin, streptomycin came out in the late 40s. And you can see how medicine has changed so much that the cost and the use of certain things, surgery and all kinds of things have happened. We had Dr. Meyer, Richard Meyer, myself were residents. He was in medicine, I was in surgery, chief residents. We started the first intensive care unit at Memorial in the late 50s. The surgical staff went to some place where the patients could be seen, watched carefully. We couldn't get we couldn't get physicians, internists to bring patients in there. They didn't want that. They wanted patients in private rooms so they could take care of them. And they couldn't do much for them. You could give injectable diuretics. You got digoxin, which has been around for 100 years. And what else? Not much. No beta blockers. No ACE inhibitors. Nothing. So the treatment of cardiac disease was in its early infancy, and there were people in Boston who were making the studies and research, but there was not much people could do. You couldn't, they were trying to make it ways to make their coronary circulation better. There were numerous operations and things. None of them worked very well, at all. So the face of medicine has changed, so that now, and people died and you didn't worry about it. You didn't have no CPR. No one knew that till the 60s.
So what would you see as the major breakthroughs between when you're a resident and now?
Well, I think the major breakthroughs are advanced in the therapeutics, in pharmacology, and in diagnosing particularly most of the diseases that we have. Surgery, a lot of breakthroughs there, technical things, but a lot of the surgical stuff, using endoscopy for investigating internal parts of you, that's all new, and doing laparoscopy and all that stuff, that's technical stuff. That, in other words, you take the gallbladder out by laparoscopy isn't any different, in a sense, than taking it out with a knife. The only difference is that the patient feels better because he's in the hospital as long, and it's less traumatic. But the idea of moving the gallbladder is the same.
Do you think that's affected, with all the new technology, do you think that's affected the way physicians view treating patients, meaning they feel like they have more of an obligation to cure as opposed to stressing, say, palliative medicine or preventive medicine?
Yes, I think the idea of curative, that we can cure anybody, permeated the medical field, but also in the patient's perceptions. That instead of going to the hospital to die, you go to the hospital to get better. And that has changed. That would change in the 60s. And I think we got to a point where, at least when I was a resident and a little later, that if you, an example, breast cancer, if we cut enough out, that means we took all the lymph nodes out internally, the axilla, the breast, the muscles, everything out, the patient would do better. And then some guy in Scotland said, "You guys are doing crazy things." And they said, "You're crazy. We know best. You McWhirter doesn't know what he's talking about." But McWhirter's ideas, which came out in the 50s, was what we do now. See? The idea being that we're not able to cure everything. Besides that, there's been a big change in attitudes towards death, make people comfortable, not to do all kinds of things to them to the last minute. And there's a movement, this spiritual movement to try to say, well, that will work better than giving lots of pills. So there's a sort of change in medical thinking, not to keep everyone alive till the last minute, and then walk away and say, well, we did our best. But the patient is just there, is just vegetable, You killed them. I mean, not even kill them, but the idea that you did too much.
Do you feel like that's being embraced by physicians now, like they're accepting?
I think so. I think, are you taught that in medical school? Anything about those things? Yeah. That the patient is, what the patient feels, and family medicine particularly has been taught, you got to get to what the patient feels. It isn't just a sore throat. Why does the patient come in with a sore throat? When I was trained, it was, well, you come in, you do a culture, or you just give them penicillin, go, and that's it. See you later. But the patient come in with a sore throat, that's only the entrance to see the physician. Why did you come here with that silly little wrist pain? That's not the problem. I want to talk about my husband who's abusing me, see? So all that's changed. You're getting back into what the patient really feels about life in general. So and doing this counseling and talking to patients is as important as giving them pills. And you have a lot of alternate stuff now. That's got into it. I mean, all this idea that the medical profession doesn't know everything. We know because we give you other alternative or complementary medication, and there's a lot in there, okay? And things like massage and all that stuff.
How do you teach students and residents to understand and use that aspect of medicine?
Well, there are several ways. One is to teach them didactically. That doesn't always work, but you observation, and also tell them to listen to patients. Some is by observation, by videotaping. We do that, and listening to how they deal with patients, and using psychologists and other people like that to teach me, and teach them. Because I had the same thing when I came 30 years ago. I was still in the mode, even though I did preventive work, which is a little different. I mean, preventive work, you just, taking care of a whole village full of cholera. That's not getting down to nitty-gritty of patients. I mean, that's what you do here. So I had to learn all that too. And then I had to teach residents that. So from the 70s onward, things like, I don't know if you know a man named Ballant. Ballant was an English psychiatrist who taught general practitioners listen to the patient. And that's what we're trying to do. Listen to the patient. The patient is telling you his condition, his disease, and telling you lots of other things about him or her.
We wanted to find out a little bit about finances in medicine. When you went to medical school, was it very expensive?
No, I went to a state school also. Mm-hmm. Wayne State is in Detroit, and I think it was $500 a year tuition, but you had, food and lodging, and that cost money, and books extra. But that wasn't very expensive. And I was a GI. I was in the Navy, so I had the GI Bill, so that helped. And I think comparably, what you pay here is equal to what I paid there, because I mean, even though you pay 2,000 or 3,000, 2,000, 3,000, whatever it is, 5,000, 8,000, is probably equal in a sense to what I was paying there, because I could buy a car for $500 in those days.
For the expensive private schools, do you think that influences the choices that young doctors make when they go into practice?
No, I don't think so. But I think our doctors, generally, medical students, when they go in, and I think statistics show that most of them idealistic when they go in. Now, when you get a $100,000 debt, you may become less idealistic. You know, say I'm going to work in Appalachia, unless there's some way you can pay off that debt. So. But I don't know. That's my opinion. So, yeah.
What have been some of your favorite things about being a physician?
Well, most favorite thing is patients. Dealing with patients, not because they, in a sense, appreciate you, but because you feel you're doing something for them, and the relationship you have with patients that you develop over years. And that's almost all doctors feel the same way. I think that the relationship is the real important thing. You enjoy looking at a young woman or a young man who you delivered 25 years ago, you know, and now is graduate from college, which I did last week. But
how do you feel the public perceives physicians nowadays as opposed to when you first started practicing?
Well, I think that we're less godlike. I think we've lost some of the aura that we had. And I think some of the problems in medicine is thrown about on the doctors in somewhat unfairly. I mean, if you go see a doctor and he spends only 5 minutes with you because he has to see so many patients per hour, that the doctor gets it. And the patient says, that's a lousy doctor, he doesn't listen to what I say. But some of it's constraints of time and the way managed care, or even if you don't talk about an HMO, what all insurance companies, what you can only compensate you for a certain amount of time. And so people are rushed. And I think patients have lost some of their feelings about doctors, and also we've built ourselves up to be able to take care of everything. Can't cure everything. That came after in the 60s and 70s when medical advances were so, you know, people didn't die anymore and people were getting better. And we can't do that. There comes a time it's limited.
You mentioned one of the things you enjoyed is the time you get to spend with your patients. Has that changed over the years? The amount of, I'm assuming you spend less time with patients.
Yeah, in a sense. Family medicine has advantage because we don't have to do everything in one day. I mean, one visit. We have a continuity of time, and especially if you're in a rural practice and stuff, even in a city practice, you have patients you see over a period of time, so you can deal with lots of things. So you can adjust, and I think a skilled family physician, or internist, primary care person, has the ability to work that out, either by doing things like phone calls instead of seeing the patient, or writing notes, or whatever they do. You can adjust your practice, but there is some pressure, but it's not unsurmountable. Yep.
What are some changes you've seen in the patients over the years? Have the patient demographics changed where you've been?
No, not much. I know the number, as far as I know about the numbers, it's in Barry, for instance, about 10% 65 and over, 10% young, or 15% under 10, things like that. Barry is a growing population anyway, but the demographics are about the same.
Since you did your residency in Worcester and then went away for so long and came back, how did Worcester change in that time, or did it?
Well, they put the expressway in. They moved populations around, so people used to we would walk down here. I mean, from Memorial, we walked down there to Water Street. That was a big Jewish area there, and get good bread and other delicacies there. The expressway cut that section of Worcester off. And there's been some population movement in Worcester. I mean, the middle class have moved out more of the west side. I suppose that's about all. But I don't. And there's more. And Worcester's lost out of its population into the suburbs. So it's kind of a stable population, about 170,000 or something like that. But I remember coming here before the expressway. I remember I came up from New Jersey, and I was in a bus, I guess, and I was coming from South Worcester. In those days, Worcester was a big industrial town. It was back in the 50s, and coming up, and it was just, the traffic was just maddening. I mean, it was just going on and on. You couldn't get through, down through South Main and up through Main Street to the north. That's a big change. The industry is heavy. A lot of, there was steel mills here. There were all kinds of manufacturing mills here. And now we have light industry, and we got other kinds of stuff, but specialized industry. But those are big changes.
What has been your involvement with the community around here?
Well, in Barry, when I'm part of the certain things of community, I'm a member of the executive board of the rescue squad. That's another thing it developed. Rescue squads developed, paramedics developed over from the 70s till now, so they're well-trained people. And I was on the school committee. And I mean, the Barry Players have a wife's into that. She's a director and an actress, and I assist in that and stuff. I do some other things in the community, in the church, and also in, I don't know if something called parish nurses, you know what those are. I don't know if you know those people, but, so some of those things.
Do you think being a physician has affected how you see community? How you see your community?
No, I don't know that question, what that means. What are you trying to...
Like, the fact that you're a physician, how has that affected your involvement, let's say, in the school committee, or has it?
A physician, and especially in a small town, has more prestige. Mm-hmm. That would be some of the things. So when I ran for school committee, I didn't have to really work at the vote, get the vote out. They knew who I was. So I mean, that would be one thing. If a position has some clout, and I probably here too, though it's different in a big city. You'd have to make some effort. That's how I see the community. I think the community. I mean, we're trying to get a community-oriented healthcare. Do you know what that is? That's been talked about. We're trying to get that in Barry so that we can listen to what the community needs and wants. I think that's the next movement in medicine, to see what they can tell us. I mean, there's a lot of voices asking for different things, but I think that would be helpful. And that may be what the physicians can do, take a lead in that.
Just a few more questions.
Sure.
Have you seen the the role of female physicians developed since when you first started practicing?
Oh, well, you know, my class in medical school, we had two, and they always had two women. Because they couldn't get one. One would be too threatening to the woman physician, so they had two. And now it's half and half, you know, 50-50. And I think that's a really good trend. That's an important trend. It doesn't really matter, though, but I don't, about female physicians, I think patients accept female physicians, and some accept them better. Young females like women physicians. I think they have a great potential to be more sympathetic, more empathetic, and more interested in the outside life of patients, which makes it easier for them to move and you know, in some things, males, we're not very, we may be sympathetic on the inside, but not on the outside. So women can do things like, especially in things like death or loss of any kind, they can be more sympathetic. And that's good. And it teaches us to get those skills down. So I think it's a good trend, yeah.
What advice do you have for younger doctors?
Well, medicine's a changing thing. And so you have to, the best thing is not fight against the trends. Try to be as well trained as you can and enjoy what you have to do, and don't make medicine the only thing you do. If you do that, you get burnt out. And therefore, but you don't want to do it the opposite way. You don't do it everything, you know, I only work 8 hours a day and I don't deal with anything else, you know. And keep your education going too. Keep reading and stuff, because medicine changes weekly in different things, in different ways. And with evidence-based medicine now, people are getting more and more, the old things we used to do are not being thrown away. And so, I don't know, have fun. Medicine is a fun thing, because you have highs and lows. If you deliver a baby or do a successful surgery at 3 a.m., that's a high. But if you lose a patient, or if you have a tough time and things don't go well and the patient is angry with you, those are down times.
Is there anything else that you feel like telling us?
No, I don't know. It's very, I think a lot of people aren't going into medicine now. The trends of numbers of going into medical school are less than they used to be. And I think that's unfortunate. I think there'll be a rebound, because I think it's a very satisfactory profession. It's a profession that gives lots of rewards, not just money. People think of money, but it isn't. It's really the idea of working with people and doing a good job and having the skill to do that.
Thank you
Good.
so much.